So very good afternoon everyone. So let's start this session. I'll start this session with a very important quote which I've been following since my school days, and this has helped me going through all the difficult phases of my life. You know, rise and awake and stop not till the goal is reached. So it's very important to keep on moving forward every day. Take one day at a time. You still have a good amount of days. Things can be done really well. You can clear this exam. So keep on focusing on one day. And very important thing which I always say to my students, that it's very important to stay disciplined. Discipline is much more important than motivation. So we may not be motivated every day, but it is discipline which will keep us going and which will help us clearing any exam which we are preparing for. So let's start the question. So let's first talk about this question. So questions you may see in the exam in different order, but we'll discuss systematically so that we are also able to understand the concept. So the question is this: a 38-year-old male presents with unusually cheerful and expansive demeanor, frequently laughing loudly, and during the interview he quickly shifts from jovial to irritable and then tearful within minutes with very little external provocation. These findings are best described as. So can you appreciate, this is a question from the MSc, a very important topic which we have covered. You know, sometimes you'll see question from this topic, and this question has been asked from the topic of affect. What is affect? Affect is the expression of emotion. So our emotions are expressed on our face, in our body language. So can we say here the patient is having a euphoric affect, the mood seems to be euphoric, and can you appreciate that without any reason or with very little stimuli there is rapid and abrupt changes in the affect. So what is this? Yes, the correct answer is option B, that is it is euphoric mood with labile affect. So we have discussed some important abnormalities of affect, and I always say please see the name. So the name will help us remember so many things. Shakespeare has said was there in the name, but I always say names are very important in psychiatry. You remember the name and it will help us remember the concept. So first important abnormality which we read is the flat affect. So when we do ECG, we see such waves. How is the ECG of a person who is dead? It is straight or a flat line. So this is the meaning of flat affect. There is no changes in emotion. So suppose we are talking to the patient and we are discussing some happy moments of his life. Recently he was promoted, recently became a father, but the patient is not showing any changes of the affect. So there is no change in the affect. Now again, let us say I am talking about some sad moments of his life. So let us say his parents died in a car accident. I am discussing that point with the patient, but patient is showing no changes in the affect. So can you appreciate, I've given positive stimulus, negative stimulus, but there is no change in the affect, and this is known as flat affect. And remember, flat affect can be seen in conditions such as schizophrenia. In fact, we will discuss flat affect or affective flattening is a negative symptom of schizophrenia. Whereas when we see labile affect, see, labile means in English something which is changing rapidly. So there is rapid and abrupt changes in emotion, like in this question. With very little stimulus, there is rapid change in the emotion. He's laughing and then within few seconds he starts crying. So this is labile affect. And also remember, it is seen in which important condition? Two important conditions which you should remember is, one is mania and another is organic mental disorder. So here, if you see the question, the right answer is option B. What is restricted affect? In restricted affect, there is limited emotional range. So the range of emotion is very limited in the patient. And what is congruent affect? Congruent affect means whether the affect is matching with the mood. So congruent affect means whether the affect is matching with the mood. If it is not matching, then we call it as incongruent affect. Again, a very important abnormality. Remember, what is incongruent affect? For example, you ask a patient, how is your mood? And the patient says like this, sir, my mood is very sad. So here, can you appreciate that the mood of the patient, he says, is sad, but when you see the affect, how is the affect of the patient? The affect of the patient is very happy. Can you appreciate here the mood or the thought of the patient are totally opposite of the affect? They are not matching. So that is known as incongruent affect. So here the answer is option B. Let's see the next question. So let us see if we can answer this question. A 30-year-old female was referred to a psychiatric clinic with complaints of not taking food for the past 1 week. When asked about it, the patient said, my intestine do not exist. How can I eat? She has been experiencing low mood, unable to sleep and decreased interest in the surroundings. What is the content of delusion and its corresponding type seen in this patient? So can you appreciate here, the patient seems to be having depression and the patient is saying that my intestines do not exist and how can I eat? So here the patient is denying the existence of the body or the organs. So what is this delusion? Can you appreciate this delusion is known as delusion of nihilism. Let's in fact talk about this very important topic. So whenever we are revising psychiatry, please revise this important topic of thought. So in the MSc, when we talk about thought, we have divided the domain of thought into 4 important categories. One is the flow or stream of thought, another is content, then we have form, and another we have possession. So delusion, remember, it's an abnormality of content of thought. So whatever the patient is thinking, there is problem in that content. And what is a delusion? Very important to remember, delusion is a false, fixed, firm idea or belief. So it's a false belief, but it is being held with extraordinary conviction. So patient has a false belief, but he is sure that what he's thinking is right. No matter any evidence you try to give that whatever you're thinking is wrong, that thought is not changing. So this is the meaning of delusion. Also remember that when we talk about delusion, we say these are unexplained by the social cultural background. Now, how this is important? Now, this line helps us differentiate delusion from a very important phenomena. Like in certain cultures, you would see that people believe that if a black cat crosses your way, something bad will happen. And they may wait for maybe half an hour, 1 hour, till the time somebody else crosses by, they may not move. So it also appears to be a false thought, but it is held with extraordinary conviction. But can you appreciate this belief is shared by other people in that society or in that culture? So it can be explained by the social cultural background. So then we call it as superstition. While when we talk about delusion, delusions are unexplained by the social cultural background of the person. And we have different types of delusion. So let's quickly revise different types of delusion. If I ask you, beta, what is the most common type of delusion? So remember, the most common type of delusion is delusion of persecution. In delusion of persecution, patient believe that somebody wants to harm me or kill me. So patient thinks that people around may be planning to kill him or harm him. Then what is delusion of reference? Very important. Reference means that patient thinks whatever is happening around him is in reference to him. So here in delusion of reference, patient believe that people are talking about me or somebody is spying on me. Now question can be asked like this, that a patient is watching television and he thinks that the news anchor in the television is giving him some secret message. What is this? So can you appreciate, he thinks that whatever is happening around him is in reference to him. Again, this is an example of delusion of reference. Let's discuss some other delusion. One is delusion of nihilism or delusion of negation. As the name suggests here, the patient is negating everything. So the patient is denying the existence of his body or the people around him, or he is denying the existence of this world. Sir, this world is a dead place. ये मरे हुए लोगों की दुनिया है. Everybody is dead here. So this is delusion of nihilism or negation. Now also remember, when we talk about delusion, we say delusion is a psychotic symptom. So it can be seen in psychotic disorders like schizophrenia, but it can occur even in other conditions. For example, can you appreciate, in delusion of nihilism, it can also occur sometimes in depression, and a patient with depression developing delusion of nihilism, then we give this term known as Cotard syndrome. So please remember this, because when we will discuss that question, we'll again come back to this term. So Cotard syndrome is a term which is given in history to a person having depression developing delusion of nihilism. Then let's talk about delusion of grandiosity. See, as the name suggests, here the patient is making false big claims. For example, patient may say that I have supernatural powers. I know famous people. Prime Minister asked me how should I run the country. I made Donald Trump the president of US again. Although his neighbor does not know him, but he claims that such famous people know him. Or he may say that I have read all the books of the universe. So this is delusion of grandiosity. So patient may claim as if I am God. So this is delusion of grandiosity. Again, can you appreciate? It can also be seen in certain other conditions. For example, we'll discuss even in mania. Delusions, hallucinations can occur, and such delusions can occur even in mania. So these were some important delusions which we have discussed. Let's come back to this question again. See, now can you appreciate here, the confusing thing is they have given you both the options. One is Cotard syndrome and also nihilistic delusion. Now the question is always focus on the last line. But what they are asking, what is the content of delusion? So what delusion is seen here? So I'm sure you can now say it is nihilistic delusion, and tell me now, is it mood congruent or mood incongruent? See, when we talk about the mood disorders we'll discuss like depression, like mania, even in those conditions we now know delusions and hallucinations can occur. In fact, any delusion can occur in depression. Any delusion, any hallucination can occur in mania. So if I ask you here, the delusion or hallucination, are they matching with the theme of the mood? So can you appreciate here, the patient is having a sad, depressed mood, and the delusion is also matching with the theme of the mood. So we say that it is mood congruent psychotic symptom. So this is the meaning when we say that the psychotic symptoms are mood congruent, whether they're matching with the theme of the mood or whether they're not matching. For example, if this patient having depression would have delusion of grandiosity. So can I say it is again a delusion which has occurred, but this is not matching with the theme? So this is what? This is mood incongruent psychotic symptom. So here the answer is option C. Let's discuss some other delusions as well. So there are certain delusions which have different names. So one of the delusions, remember, is Othello syndrome, also known as delusion of infidelity. But what is infidelity? Infidelity means that the patient believes that my spouse, my husband, my wife is having an affair, also known as morbid jealousy. So here the patient believes that my partner is cheating, is having an extramarital affair. Everybody is trying to convince him otherwise, but he's not changing his belief. So this is what? This is delusion of infidelity. Now again, remember, it can be seen with other conditions. So one of the important substances, if I ask you, can you tell me an important substance with which you may see delusion of infidelity? So which is the important substance? Patient consuming that substance for a long time. Next time this question may be asked as a new question, that a patient has delusion of infidelity, which of the following substance he is consuming? So remember, a very important substance which can lead to this delusion is alcohol. Another delusion, see, which has different names. So one is de Clerambault syndrome, also known as delusion of love. Now when you say love, you say I love that person. But here in delusion of love, the patient says that somebody else is in love with me. So this is also in fact known as erotomania, and remember here the patient claims that someone else is in love with the patient. For example, a 25-year-old female claims that superstar Salman Khan is in love with her. She says that wo jo movie आई थी, that movie which came of Salman Khan, Kisi Ka Bhai Kisi Ki Jaan, in that Jaan was me. The Big Boss show which Salman Khan hosts, in that show the eyes of the Big Boss is telling me that he's looking for me, although the actor might have never met this patient, but the patient claims that he's in love with her. So what is this delusion? This is delusion of love. Let's also discuss, let's clear these two delusions as well. So let's talk about delusional misidentification syndrome. See, as the name suggests, misidentification. So here there is problem in the identity of the other person. Again, there are two important syndrome which we'll discuss. One is Capgras syndrome. Now, what is Capgras syndrome? Again, I always say, remember from the name. So Capgras syndrome, if you see, just see the name. So just see the alternate word, C for close, P for person, replaced by a stranger. So patient has this belief that a close person, a person closely related to me, has been replaced by a stranger. So this is Capgras syndrome. For example, let us say a patient, Mr. Cap, who is admitted in the hospital, his actual wife comes to meet him in the hospital. But when he sees his wife, he says, "You're looking like my wife." Of course, she will look like the wife because she's wife only. But he says that you're looking like my wife, but you're not my wife. You are a hospital nurse in disguise who has come to meet me. So can you appreciate what is happening? He thinks that a close person, in this case his wife, has been replaced by an imposter, by a stranger. So this is Capgras syndrome. Now always remember this trick. So whenever you are seeing this patient, try to remember this trick. See for Capgras syndrome, always see with whom the patient is fighting or arguing with. So can you appreciate here the patient is arguing with the wife, with the close person. So remember here the patient is arguing or fighting with the close person. Also remember, if I ask you, can you tell me an important dementia in which patient may develop Capgras syndrome? In fact, we'll discuss this point, that in one of the causes of dementia, Capgras syndrome may be seen. So can you tell me which dementia I'm talking about? It's a very important dementia we'll discuss, starting with L, that is Lewy body disease. It is a supportive feature of Lewy body disease. Now just the opposite of Capgras you can remember is Fregoli syndrome. Now what is Fregoli syndrome? In Fregoli syndrome, a patient believes that a familiar person, here he thinks that a person I know, a person who is familiar to me, is imposing as a stranger in front of me and can take multiple appearances. Let's bring one more patient. Let us say we have a patient, let's call him Mr. Freg. He was walking and he saw a stranger, let's call him S1. So he has never met this person, he saw a stranger, and when he sees the stranger, he says, "You're looking like a stranger, but you're not a stranger. You are my wife in disguise. What are you doing here? Go back home, go back home." He walks further. Again, he sees another stranger, let's say he's S2. Again, he says to the stranger, "You're looking like a stranger, but you're not a stranger. You are my wife in disguise. What are you doing here? Let's go home, let's go home." So here he thinks that a familiar person is imposing in front of him as a stranger and can take multiple appearances. Sometimes they may show you such images that a person is changing different masks. So as if the person can change different appearances. This is Fregoli syndrome. Again, remember the trick. If I ask you here, with whom he is fighting with, so try to see in the question. Here, can you appreciate he is fighting with the stranger, that you're not a stranger, you're a person I know. So this is Fregoli syndrome. So I hope this is clear to everyone. Delusion is an important topic. So please remember this. Let's discuss the next question now. A 32-year-old woman who has performed well in her personal and professional life believes her co-workers are whispering about her, hiding her belongings, sabotaging her work projects. Despite having no evidence, she feels anxious and increasingly isolated. What is the most likely diagnosis? Again, can you appreciate in this question there is a false belief in the mind of the patient that people around him are sabotaging their work, are trying to harm her. So what is this? Can you say this is a delusion? Now which delusion? Is it delusion of infidelity? Of course no. Is it delusion of erotomania? No. Is it delusion of grandeur or grandiosity? No. So this is answer is delusion of persecution. Let's discuss the next question. Now on psychiatric evaluation, a 30-year-old female, when asked about what she did that morning, she said, I went to supermarket. The supermarket's logo was in yellow color, which reminded me of the sun. I like the sun a lot more than the moon. I don't understand how the astronauts are able to go to the moon with such pathetic costumes. Went on to talk about it for a long time in a rapid pressured manner. What term best describes the patient's presentation? So let's try to answer this question. The options are clang association, B circumstantiality, C loosening of association, or is it D flight of ideas? So a very interesting question. Please remember again, this question is from the disorder of thought. Now when we talk about disorders of thought, first entity which we have covered is the abnormalities in content. Let's now also discuss some important abnormalities in the flow or stream. Now what do you mean by flow or stream? So if you sit silently, you will observe just like in the river, the water is flowing. Similarly, in our minds, the thoughts are flowing. So this problem can be of the flow of thought. Now, one important abnormality in the flow is flight of ideas. Now, again, see the name. Flight of ideas. This term is telling us that the ideas are on a flight. So the thoughts are moving very fast in the mind of the patient. So the speed of the thought is very fast. One thought, second, third, fourth, fifth, they are coming very fast. And patient may say a lot of things which may not make much sense. And also remember, ultimately the patient doesn't answer the question. So remember, the goal is not reached. But when you hear the thoughts of the patient, you will see that there are some connections between the thought. So the thoughts may be connected by chance connection. For example, a patient may speak like this. My name is Virat. I like playing cricket. Cricket is a game of gentlemen. Gentleman is my friend Mukesh. Mukesh smokes cigarette. Cigarette causes cancer. Cancer is my zodiac sign. ये मौसम की बारिश, ये बारिश का पानी, ये पानी की बूंदे तुझे ही तो ढूंढे, something like this. So things are not making much sense, but they're connected by chance. Or the thoughts may be connected by clang association or rhyming word. For example, a patient may speak like this. Ram can sing, birds have wing, I am the king, phone goes ring ring, the weather is spring, bring 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 bring. So can you appreciate patient is saying a lot of things very fast, not making much sense, and there is some connection between the thoughts, the goal is not reached. This is flight of ideas. And if I ask you one important condition, can you tell me where would you see flight of ideas? Remember, flight of ideas can be seen in condition like mania. In fact, in mania, when we read the symptoms of mania, we use a mnemonic me dig fast. In that F is flight of ideas. So again, can you appreciate here the patient is saying a lot of things. Although here, in fact, they have also mentioned the speech, the speed of the speech, that it is rapid, pressurized manner, the speech is increased. So again, this is a very important clue for us. So patient is saying a lot of things, not making much sense, and you will see there is some connection. For example, I went to a supermarket, supermarket's logo was yellow and it reminded me of the sun. And I like the sun a lot more than the moon. I don't understand how the astronauts are able to go to the moon with such pathetic costumes. So can you appreciate there is a by chance connection as well? So here the right answer is it is flight of ideas. Now also remember, in loosening of association we'll discuss it's an abnormality of form. Now what happens in loosening of association? There is breakdown in the logical connection between the thought. So here you are able to understand some part of the sentences, but in loosening of association we may not be able to understand the sentences. You will say I am able to understand the words, but I am not able to understand what the patient is trying to say. And of course it is not circumstantiality, which we will discuss, and it is not clang association. In clang association you will see that there is rhyming words, so they are connected by rhyming. So let's discuss in fact this abnormality, which is circumstantiality. So we've been discussing, but a circumstantiality is what? It is also an abnormality of flow or stream. Here in fact remember the thoughts are moving very slowly. So in the mind of the patient, the thoughts are moving very slowly. But very important point for circumstantiality is that whatever the patient is saying, he is saying unnecessary things, or he is saying things which are not required, which are trivial information, which you have not asked for. But patient is giving you those unnecessary details, and ultimately the patient answers your question. So we say that the goal is reached. So for example, if a patient has to go from A to B, rather than going straight, the patient is going like this. He is giving unnecessary information and finally he is reaching the goal. For example, this example we always discuss, you ask a patient, who is your favorite actress? The patient says, Sir, Alia Bhatt acts very well. I watched most of her movies, but I was upset for a few days when I heard she's getting married, but may God bless her. Even Katrina Kaif is a wonderful actress. I was upset for a few days when I heard she's getting married, but may God bless her. Even Kareena Kapoor is a wonderful actress. I have seen all her movies starting from Refugee. I was upset for a few days when I heard she's getting married, but may God bless her. My favorite actress is Kiara Advani. So can you appreciate patient has given unnecessary information, but please remember here, everything which the patient is saying is making sense. You are able to understand everything, but these are unnecessary. And ultimately the patient answers the question. So please see this question. If you see this question, even if in the question they have not mentioned that the speed is increased, still, can you appreciate patient is saying a lot of things which are not making much sense, and there is some connection like by chance or clang association it could be, then we say it is flight of idea. So it is not circumstantiality. Very important. Now also let's discuss another important abnormality of flow or stream, which is perseveration. Now let's also discuss this last point, perseveration. Again, highlight this in your notes, very important. You may see some new questions from this. Now what is perseveration? So remember, in English, when I say what is perseveration, perseveration means to repeat something. So remember 3 P's. P for perseveration, a thought persists beyond the point of relevance. So in the mind of the patient, there is one thought which is now getting repeated, although it is not relevant. So this is perseveration. For example, in the question they may ask you that a patient is answering all the question with the same answer. Or they may give you such clinical situation that you ask a patient, what is your name? The patient says, my name is Mukesh. It is correct. It is relevant. What do you do? My name is Mukesh. Where do you live? My name is Mukesh. What is the name of your wife? My name is Mukesh. Now can you appreciate this one thought? Initially it was relevant, but now it is getting repeated beyond the point of relevance. So as if the patient is stuck at one thought, he is not able to go forward. So can you appreciate this is also a problem of flow. So this is perseveration. So if you've seen Avengers, anybody seen Avengers? You know, what is your name? I am Groot. What do you do? I am Groot. Where do you live? I am Groot. So this is perseveration. Now also, if I ask you 2 important conditions where you may find perseveration, also remember this order. First important condition is organic mental disorder. So in organic mental disorder, you may see perseveration, and another important abnormality is schizophrenia. So remember, this is perseveration. Also, you know, sometimes you will see that patient may keep on repeating the word with increasing frequency, or may just repeat the last word again and again. So for example, a patient when says, I want to go home, home, home. This is an example of, so they may just ask you this question. So can you appreciate when he says, I want to go home, it seems to be a relevant thing, but now he's repeating the last word again and again, home, 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 home. So this is what? Again, this is perseveration. We'll remember perseveration, and we'll also try to distinguish it from some other abnormalities. But remember, perseveration means initially it is relevant, but it is now being repeated beyond the point of relevance. I hope this is clear. This is perseveration. So we have covered some important abnormalities under the flow or stream. Let's discuss now the next question. A 30-year-old male is admitted in a psychiatric ward for psychotic behavior over the past 8 months. The patient's mother says that his son is speaking things like he knows the USA president, and patient is the one who actually is running that country. When he spoke, his sentences did not always seem to have any connection with each other. Also, he is using some terms like prat, nit, wit, kit, filtlo, which is not making any sense. He also claims to be followed by terrorist groups to kill him. Which of the following symptom you have to tell me is not seen in the patient? So this question is testing a lot of your concept. You have to tell me which of the following phenomena out of these 4 options is not seen here. So let me see if you can answer this question. So can you appreciate, again here we are discussing some abnormalities of thought. So here first is delusion of grandiosity seen here. So here the patient is talking things like this, that he knows the president of USA, and he's the one who's actually running the country. So this is again telling us that here delusion of grandiosity is seen. Now let us see, is neologism seen here? So in fact, let's talk about some important abnormalities of form, then we'll correlate this with the abnormality seen in the patient. So form means organization. Normally our thoughts are organized, they are connected. You will see any thought you pick up coming in your mind, that will have a start, it will have a middle part, and it will have an end. Everything is logically connected. So normally हमें अपने thoughts समझ में आते हैं. We are able to understand our thoughts. They are logically connected. They are organized. But when there is abnormality of form, we call it as formal thought disorder. So again, the name formal means there is abnormality of form. So formal thought disorder means that the thoughts are disorganized. So there is disorganization of thought. And if I ask you, can you tell me an important condition where you will see formal thought disorders? So remember one disorder which we will discuss, such as schizophrenia. In schizophrenia, patient may have disorganized speech or disorganized thinking. So always see the name. First abnormality is loosening of association. As the name suggests, the association between the thoughts that has loosened up. So there is loosening of association. That means there is a break in the logical connection. The thoughts which were logically connected, now that logical connection is gone. For example, if you ask a patient, what do you want to, if you want to do, watch a movie outside, what will you do? So the patient may say, sir, I will watch, I will buy ticket, I will book a cab, I will reach cinema hall, black umbrella. So can you appreciate here, words you are able to understand, but you're not able to understand what he's trying to say. So this is loosening of association. While when we compare it with flight of ideas, remember in flight of ideas also things will not make much sense, but there is some connection between the thoughts. Here there is no such connection, but there is breakdown in the logical connection between the thoughts. What is neologism? Again, just see the name. Neo means new and logos means words. So patient is using some new words which are not present in the language known to him. Like in this scenario, can you appreciate he is saying this word pratnet kit wit fitlo, and it is not making any sense. He knows only English language, let us say, and you've searched Oxford dictionary, you have googled this word, nowhere this word is seen. So this is what? This is neologism. Also, can you appreciate in the question it is said that sentences did not always seem to have any connection with each other when he's speaking things. That sentences are not making much sense. So this is what? This is again suggestive of loosening of association. Is perseveration seen here? Can you appreciate here? No phenomena of perseveration is seen. So here the right answer is option D, that is perseveration. Also, can you tell me one important abnormality more which can be seen? He thinks that the terrorist groups want to kill him. So there is also delusion of persecution. So here the right answer is option D, perseveration is not seen. Let's complete this. Let's complete some other important abnormalities of form. Next is derailment. Again, but I always see the name. So what do you mean by derail? A train is moving on track and suddenly it gets derailed. So a patient is talking about a topic and suddenly he changes the track, and there is no connection between the two thoughts. So there is sudden jumping of the track and patient moves to a new topic, and you're not able to understand the connection. For example, if you ask this patient, what will you do if you want to have food outside? The patient says, sir, I will book a cab, I will reach cafe, and suddenly changes the track. Sir, IPL matches have started. Now I'm rooting for my favorite team. I hope this team wins now this IPL. So can you appreciate he's on the track for some time and suddenly he changes the track. So this is derailment. Also, what is tangentiality? See, again, just see the name. What is a tangent to a circle? It's a line which touches the circle and it goes away. Does a tangent ever return to the circle? No. So this is tangentiality. Tangentiality means the patient just touches the topic and he goes away, and he never answers the question. Now sometimes circumstantiality is compared with tangentiality. In circumstantiality we discuss patient is giving unnecessary information but reaching the goal. Here in tangentiality, patient just touches the topic. For example, you ask the patient who is your favorite actress. The patient will just touch the topic and say, sir, I like Indian movies, especially the dances. In fact, Shahid Kapoor dances very well. And coincidentally, sir, I was watching his movie Kabir Singh, and in fact, I am also planning to take up orthopedics, and the patient just goes away. So this is tangentiality. Also remember how to differentiate derailment from tangentiality. Very, very important. In derailment, remember for some time the patient remains on the topic and then he changes the topic and there is no connection. While in tangentiality, from the beginning, he just touches the topic and he goes away. What is verbigeration? Also, let's discuss what is verbigeration. Now, verbigeration is senseless repetition of words. So please differentiate it from perseveration. In perseveration, we discussed initially that answer was relevant, What is your name? My name is Mukesh. And now it is being repeated beyond the point of relevance. While in verbigeration, there is just senseless repetition of words, phrases or sounds. For example, a patient says, I am umbrella black. I am umbrella black. So here there's just senseless repetition of words, phrases or even sounds. In fact, extreme form of verbigeration is also known as word salad. Like everything is mixed up in a salad, so this is word salad. Let's now discuss the next question. A man hears a voice commanding him to lock all the doors in his house immediately, warning that he is in danger. The voice is persistent and direct, addressing him personally, saying, "You must lock the doors now or something terrible will happen." Despite no visible threat, the man feels compelled to follow the voice's instruction. What is the diagnosis? Now, can you appreciate here the person is hearing some voices. So here it's a problem of perception. Now let's discuss some important abnormalities of perception. So what is the meaning of perception? Perception means how we experience or perceive the external environment. So for example, you can hear me, you can see me, you can smell things around, you can taste things also. There is a sense of touch, right? So this is what is perception. So sometimes there may be problems in perception. Can you appreciate here there is no actual person, but person is hearing something. So this is in fact an example of hallucination. Let's in fact discuss first two important abnormalities in perception. One is hallucination and another is pseudo hallucination. Now here both are false perception without any real object. Like in this scenario, actually there is no source of voice, but the person is perceiving something. So this is hallucination. Also this is similar definition is of pseudo hallucination. In fact, hallucination when we talk about or pseudo hallucination, the person is experiencing it very clearly. For example, this patient is hearing it very clearly. He can also say what he's hearing, what the voice is saying. Also, it is independent of the patient's will. Patient would say that it is coming and going on its own. It is not under my control. And of course, it is without any real object. So what is the difference between hallucination and pseudo hallucination? In fact, if you watch this movie, in this movie, Munna Bhai can see and hear Mahatma Gandhi. We know Mahatma Gandhi is no more with us. But usko Mahatma Gandhi sunai de rahe hain. He can hear him and also see him. His friend circuit says there is no Mahatma Gandhi. Others cannot see, but he is able to see it very clearly. And where is he seeing it? He is seeing it in the outside space. So remember, hallucinations, they occur in the outer objective space. While pseudo hallucination, remember, they occur in the inner subjective space. Now what is inner subjective space? Suppose if I ask you to create an image of the last hilly area you have been to, you will be able to create that image in your mind. Now I tell you, you spend a lot of time there. Let's come back to the class. So you'll come back to the class. Where that image was created, it was created in the inner subjective space. So in pseudo hallucination, patient will say that I can see someone, but it is in my mind. It is very clear, not under my control. So that will be example of pseudo hallucination. Also, we know that there are different types of hallucination. Now, based on the different modalities, one is auditory hallucination, there is visual, tactile, olfactory and gustatory hallucination. Now, if I ask you most common delusion in psychiatric disorder, you would say delusion of persecution. If I ask you which is the most common hallucination in psychiatric disorders, please remember the most common hallucination in psychiatric disorder is auditory hallucination. Now, patient can hear anything. He could hear any bell ringing or a dog barking or a human talking. But when a person is hearing human voices, that can be further divided into three categories. One is first person auditory hallucination. Now in first person auditory hallucination, patient is hearing his own thoughts. So patient says, sir, a thought comes in my mind. Suppose a thought comes that I want to go and eat food outside. And as soon as this thought comes, he also hears a voice coming from outside repeating that same thought. I want to go and have food outside. So this is what? This is first person. Now what is second person auditory hallucination? Now what is second person in English grammar? When somebody is talking directly to you, then you are the second person. So in second person auditory hallucination, suppose this is the patient. Patient says, I hear a voice which is directly talking to me. Like in this question, can you appreciate here? He can hear a voice which is directly talking to him, and sometimes these voices may command the person to do something. In fact, here they have given you example of a second person auditory hallucination known as command hallucination, that the voice is also commanding the patient to do something. So can you appreciate here? The answer is it is second person auditory hallucination. Now what is third person auditory hallucination? Here the patient says that I can hear few voices which are talking to each other and I can hear their voices. So this is what? This is Third person. So in English, when you use third person, when somebody is talking about you, then in that conversation you are the third person. So this is the meaning of third person auditory hallucination. And some examples you can remember, like the patient may even say that the voices are discussing about me. So the patient says that these voices now are talking about me also, that they are saying, look, he's such a bad person, yesterday he shouted on his mother, he should not have done this. And also one more example you can remember is running commentary. Now what is running commentary? Like when you're watching any sports channel, for example you're watching cricket, there is a running commentary going on. Whatever the players are doing, the commentators are talking. Similarly, patient says, sir, when I wake up, I hear a voice which is repeating whatever I am doing. Like he may hear a voice that, look, he has now got up from the bed. Now he's going to the washroom. Now he has come back. Now he's preparing his meal. Now he's getting ready for the office. So it is going on in the background. It is not directly talking to him. So this is also an example of third person auditory hallucination. So here the answer is option B, that is second person auditory hallucination. Now also let's come back to these different types of hallucination. Second is visual hallucination. Here the person is seeing things which are not seen by others. Again, it could be anything. The patient is, let us say, seeing some object or an animal or even a human being. A very important point here is, if I ask you visual hallucination, but a visual hallucination is given in the question, can you tell me one important disorder which you have to look for in the question? Sometimes you will see that they may give you this disorder associated with visual hallucination. So very important point, remember, it is organic mental disorder. In fact, if I ask you in organic mental disorder, most common hallucination, it would be visual hallucination. Of course, remember, hallucination is a psychotic symptom. So any of these hallucination can be seen in conditions like schizophrenia and even in other conditions. But remember, visual hallucination, try to see in the question if they're talking about any organic mental disorder. Then there is tactile hallucination. Patient reports that he can feel, let us say, small insects crawling over or under the skin. This is also known as formication and also known as cocaine bugs or magnum bugs. Why it is known as cocaine bugs? Because it can be seen with cocaine users. A patient comes to us with tachycardia, tachypnea and scratch marks. Which substance he is consuming? Now, can you appreciate these scratch marks are telling me that patient may be having these tactile hallucination, he is trying to remove them. So in the physical finding, you may see scratch marks. Why tachypnea, tachycardia? Because we know cocaine is a stimulant. So when a person is using cocaine, remember, there is increase in the sympathetic activity, hyperthermia. And tell me in the eyes, somebody is consuming cocaine, tell me in the eyes what you will see. Meiosis or mydriasis? Remember, you will see mydriasis. So very important point, again remember. So patient developing delusions, hallucination, they may tell you that patient is having tachycardia, tachypnea, scratch marks, tactile hallucination is there. So which substance he is consuming? Then you're thinking of cocaine. Then what is olfactory? The patient is smelling something, is able to smell something although there is no object. So patient comes in a room, all of us are sitting very comfortably, but the patient says, so there is a very bad pungent smell coming from the room. We cannot, smell anything, but he is able to smell it. So this is what? This is olfactory hallucination. Gustatory hallucination is taste. There is no object on his tongue, no food on his tongue, but he is able to appreciate some taste. So this is gustatory. Now again, these hallucinations can be seen in condition like schizophrenia. But remember one important lobe abnormality. If I ask you in which lobe abnormality would you see these hallucinations? Can you tell me which lobe abnormality? So remember, in temporal lobe disorders like temporal lobe tumor or temporal lobe epilepsy, also sometimes you will see these hallucinations. So such question may be given that a patient has a road traffic accident, there is some injury in the brain, they may also give you a CT or an MRI, and patient has developed these hallucination, olfactory, gustatory hallucination. Which area abnormality you are suspecting? Temporal lobe abnormalities. Now let's discuss the next question. A 35-year-old male patient reports that whenever he hears the sound of a church bell ringing, he vividly sees the face of his deceased father floating in front of him. When the sound stops, the visual image also disappears. Now here, can you appreciate, patient is experiencing the face of his deceased father. So he is having a visual hallucination. But this visual hallucination, normally we discuss that hallucinations occur without any real object. But it's a special hallucination. Here hallucination is occurring after a real object. And here, can you appreciate that the real object or the real stimulus is in which modality? So can I say it is in auditory modality? So whenever he is hearing the church bell ringing, he sees his face of his deceased father. So a auditory stimulus is producing a hallucination in a different modality. So what is this known as? Remember, this is known as, let me see if you can answer this question. Which hallucination out of these four? Remember, it is reflex hallucination. So what is reflex hallucination? Remember, it's a very old MCQ. This has been asked previously. It is also known as morbid synesthesia. So here, a normal stimulus in one sensory modality is provoking a hallucination, remember, in a different modality. Like suppose a patient says that whenever I listen to the radio, I turn on the radio, I see colors in the air. So this auditory stimulus is producing visual hallucination like mentioned in the question. So that is reflex hallucination. As a reflex, hallucination is produced. Also, if it is asked, beta, which substance use can lead to this hallucination? So hallucinogens like, remember, LSD, lysergic acid diethylamide, they can produce reflex hallucination. So I hope this is clear to everyone. This is reflex hallucination. What is functional hallucination? Here, the real object in one modality produces a hallucination in the same modality. So for example, a patient says, whenever hear the church bell ringing and also hear voice of a man coming from outside the room, which no one else can hear. So here a real object which is auditory is producing auditory hallucination. Then we call it as functional hallucination. Now what is extracampine hallucination? Here the hallucination is occurring beyond the sensory field. For example, a patient is in Delhi. He says he can hear the voice of his friend, so it's auditory hallucination, but he says that voice is coming from USA, United States of America. So can I say this is beyond the sensory field? So this is extracampine hallucination. What is autoscopic hallucination? Here the patient says that I can see myself outside of my body and also knows that other person, that is me only. So this is autoscopic hallucination. Here the right answer is, it is option B. Let's discuss the next question. So one more question we'll discuss from the MSc. So remember, in MSc, delusion, that is abnormalities of thought and abnormalities of perception, are very important. Let's now see this question. During a mental status examination, a patient is asked to explain the meaning of the proverb, people who live in the glass houses doesn't throw stones. He replies, because the glass will break if you throw a stone at it. The response is most indicative of. Now this is a very interesting question. Let me see if you can answer. Now here, can you appreciate, you have asked a proverb. This is a proverb which we have asked. You must have heard of this proverb. जो लोग शीशे के घर में रहते हैं वो पत्थर नहीं फेंका करते. This is the proverb. Now can you appreciate, proverb has a hidden meaning. So what are we actually assessing here? So can you tell me what we are assessing here? Here we are assessing the abstract thinking of the patient. So abstract thinking means whether the person is able to understand the deeper meaning or the person is able to form concept. Normally all of us are able to understand the hidden meaning. In fact, nowadays you might be seeing a lot of memes on social media. If you are able to understand the memes, the meaning of those memes, that means you are able to understand the hidden meaning, you are able to have a good abstract thinking. So normally all of us have abstract thinking, but sometimes abstract thinking may be impaired. So let us discuss two tests which we use to assess the abstract thinking. One of the test is proverb testing. For example, here when we ask the meaning of this proverb, what is the actual meaning of this proverb if I ask you? So you will say, sir, people who have flaws, they should not criticize other people with similar flaws. That is the actual meaning. So here, can you appreciate, the patient is not able to understand the meaning. He is not able to understand the deeper meaning only. He is able to explain it superficially. So what is this? This is loss of abstract thinking. Remember, so here I can say that abstract thinking is absent, and the term we use for loss of abstract thinking is concrete thinking. So concrete means superficial, as if the person is not able to go deeper into the meaning. He is only able to understand the superficial meaning. So here, can you appreciate, here they have given two options. One is abstract thinking and one is concrete thinking. What would be the right answer? What would be the better answer you would mark here? Please see this. We are assessing abstract thinking, but here from the answer it appears that the abstract thinking is lost or it is absent. So here the better answer would be, it is concrete thinking. Let's discuss one more test which we do to assess abstract thinking, that is similarity testing. So we ask similarity between two objects. Suppose if I ask you, tell me the similarity between a car and a plane. So what is the similarity? All of us would say, sir, both are mode of transport. So we are able to understand the larger, the bigger meaning. So we are able to understand the functional similarity. But suppose a patient says he only gives structural similarities. For example, patient says, sir, both of them have tires, or both of them have seat, both of them are made up of metal. So can you appreciate, here he is only able to give me the superficial similarities, only the structural similarities, not the deeper similarity. So where would I say that abstract thinking is present? When the person is able to tell me the functional similarity, I'll say abstract thinking is present. Here I would say abstract thinking is absent. And again, loss of abstract thinking is known as, remember, it is known as concrete thinking. So here the right answer is option B, that is concrete thinking. Now, what is autistic thinking? Autistic thinking, in fact, when you talk about schizophrenia, we read Bloyler's 4A's. Now, what are Bloyler's 4A's if I ask you? So, one is loosening of association. Loosening of association, history of schizophrenia, we talk about Bloyler, who also coined the term schizophrenia. So, he gave 4A's. He said that these are the 4 symptoms of schizophrenia according to him. Second is affective flattening. Again, both these phenomena we have already discussed. So loosening of association is a formal thought disorder we discussed, can be seen in schizophrenia. Another is affective flattening or flat affect or blunt affect, again can be seen in schizophrenia. Third is autistic thinking or autism. Here autistic thinking means illogical thinking. In fact, this question was asked recently in the exams. A patient says, Lord Hanuman was a celibate. I am a celibate. That means I am Lord Hanuman. So can you appreciate here there is no logic in his thinking. So the answer there was, it is autistic thinking. And the last A, can anybody tell me what is the last A? Remember, that is ambivalence. Now what is the English meaning of ambivalence? Sometimes when you wake up in the morning you say, sir, I'm not able to decide whether should I wear white dress or red dress. I'm being very ambivalent. So ambivalence means not able to decide. So in the thinking, the patient is not able to decide. For example, there is a pen on the table and the patient is staring for hours and hours, thinking in his mind, should I pick this pen or not? So what is this? This is ambivalence. So these are the 4 A's given by Bloyler for schizophrenia. Let's now see the next question. So we have covered some important points from the MSc. Now let's talk about the disorders. Now in the disorders, first we'll talk about some organic mental disorders. So let's see this question. A 30-year-old male was admitted for hip replacement surgery on the second post-operative day in the hospital. He appeared confused and would continue to say that he is at his home. He would appear very irritable and would sometimes try to remove the catheter. Which of the following is the likely diagnosis? Very good. Yes. The answer is what? Now I've marked some important keywords in the question. Always try to appreciate these keywords. See, it's an elderly person, undergone a surgery, second post-operative day, some symptoms have developed. So very good. You're thinking of delirium, but can you tell me what is the important point which is led to this diagnosis of delirium? So what in the question point is mentioned which is telling you that it is delirium? So can you tell me what point in the question has told you that it is delirium? See, let's now talk about the organic mental disorders, and remember in both DSM-5 and ICD-11 now it is known as neurocognitive disorder. So as the name suggests that there is cognitive impairment. Very good. Yes, the patient is not oriented. Very good. So as the name suggests, there is cognitive impairment in the patient and there is a cause. So there is a cause which is causing these cognitive impairment. Now one important abnormality is delirium. Now what is delirium? Very important point. In delirium we say that both consciousness and cognition is impaired. So it's a neurocognitive disorder. Cognition is also impaired and very important, consciousness is also impaired. Now what is consciousness? It is awareness of self and surrounding. Right now all of us sitting, we are conscious, we are aware of ourselves, we are aware of our surroundings. So how would you know in the question that they're telling you that consciousness is impaired? So I always say this trick, remember this trick, ACDC. Somewhere in the question they tell you that altered sensorium is there, or they may tell you that there is clouding of consciousness. That means in the clear sky of consciousness now there are clouds. Abhi badal aa gaye, it is not clear anymore. Or somewhere in the question they are trying to tell you that patient is disoriented to time or place or person, or they may just tell you this term, there is confusion. So this is suggesting that the patient's consciousness is impaired, and when consciousness is impaired you're thinking of delirium. Of course cognitive impairment can be there, like memory may be impaired, language impairment may be there, even perceptual abnormalities may be there. Can you tell me which perceptual abnormalities better you would see here? Very important, we have discussed. Remember, visual hallucination may also occur in the patient. So delirium matlab both consciousness is impaired and cognition is impaired. Can you appreciate in this question? They're telling you that the patient is confused. The patient says he's at his home although he's in the hospital. So the patient now has developed disorientation. So here we are thinking of delirium. Now also remember, there is a close differential diagnosis. Suppose somewhere in the question they would give you this history that acute onset, delirium usually occur acutely, sudden onset is there. So there is acute onset, also fever is given in the history. Now fever when is given, you are thinking of some organic condition, and patient has developed delusions, hallucination, which can also occur in delirium as well. So one of the differential diagnosis could be delirium, but of course delirium you will make only when there is mentioning of impairment of consciousness. Can you tell me another important differential diagnosis of this condition? So what you may be suspecting here, if consciousness impairment is not given in the question, so one more important differential diagnosis, remember, is acute psychosis. So what is acute psychosis? It means symptoms are similar to schizophrenia, but the duration is less. So please remember this point. Again, I am repeating that sometimes fever may also be given in the history of acute psychosis. Sometimes acute psychosis may have a fever as a stressor, which may be given in the question. So please remember here, acute psychosis you would make if the consciousness is not impaired, then I'm thinking of acute psychosis. So this was a delirium. Another neurocognitive disorder is dementia. Now in dementia we are saying that the consciousness is intact, it is not impaired, it is only the cognition which is impaired. For example, patient has amnesia. Now what is amnesia? Amnesia is impairment of memory. So there is memory problems in the patient. Or they may tell you there is aphasia. What is aphasia? There is language impairment. The patient is not able to use words properly. He is making a lot of grammatical errors. Then what is apraxia? Praxia means movement. So what is apraxia? There is problem in fine learned movement. So somewhere in the question, they will tell you that patient is not able to comb his hair, he's not able to button and unbutton his clothes, he's not able to tie and tie the shoelaces, he's not able to use the laptop. So there is problem in learned fine movement, so that is apraxia. What is agnosia? Agnosia means patient is not able to identify object. So in our final year, when we are doing the CNS examination, we show some objects to the patient, ask him to identify. You ask him to identify this pen, he is not able to identify. So this is agnosia. Sometimes patient is not able to identify faces, that is known as prosopagnosia. Again, see, in the name agnosia is coming. So sometimes when you are seeing or solving such question, try to see the names as well. Sometimes just by seeing the name you are able to answer the question. Now also remember, there is one important assessment tool for delirium. If I ask you what is one important assessment tool, that is CAM, confusion assessment method. In fact, this question was asked previously in one of the exam. Suppose if I ask you confusion assessment method is used for, now we know confusion is seen in delirium. So yes, it is used for delirium. So please remember this as well. Lastly, we also have amnestic disorder. See, in delirium we discussed both consciousness and cognition is impaired. In dementia we are saying only there is cognitive impairment. In amnestic disorder, again as the name suggests, out of the cognitive functions it is only the memory which is affected. So this is amnestic disorder. So here the main complaint is problems in memory. Also remember, there are different causes. Like there can be CNS causes, like there is a seizure, trauma. There can be so many CNS causes of amnestic disorder. Also there can be systemic causes. One important systemic cause about the causes of dementia, many of the causes are irreversible, they are progressive. So usually we say that dementia is a progressive cognitive impairment. But there are some causes which are reversible. That means if you identify those causes and you treat them, dementia would be reversed. So let us see if we can answer this question. So we'll discuss a very important table in fact. See, so we have normal pressure hydrocephalus, hypothyroidism, hyperthyroidism, Lewy body dementia, vitamin B12 deficiency. So let's try to see this table. So let's discuss nearly 10 to 15% causes of dementia, they are reversible. Dementia would be reversed. There can be intracranial causes like tumor, or there is brain abscess that can also cause reversible dementia. NPH, very important. What is NPH? Anybody? It is normal pressure hydrocephalus. So because of that also dementia can occur, normal pressure hydrocephalus. And what is the classical triad? Patient has cognitive impairment, gait abnormality, magnetic gait, and urinary incontinence can be seen. And how do we treat? It is treated by ventricular shunting, and you treated, the dementia may be reversed. Also, there may be infection causes such as encephalitis, meningitis. You treat them, the dementia would be reversed. Very important, let's discuss some metabolic causes. Now, if I ask you, any one important deficiency, vitamin deficiency that can cause reversible dementia, but if they ask you one, very important, remember vitamin B12. Also remember even niacin, folate, even thiamine deficiency can also cause reversible dementia. And in the endocrinal abnormality, one important abnormality if it is asked, remember it is hypothyroidism. But remember, even hyperthyroidism, even hyperparathyroidism can also cause reversible dementia. And in others, one important substance, if I ask you, consuming that substance can cause dementia. But if you tell the patient to stop that substance, within a year, even the brain changes which have occurred, they may also be reversed. So which important substance I am talking about? Remember, even alcohol can cause reversible dementia. So these are some important causes of reversible dementia. See, question may be asked like this. So here, can you appreciate normal pressure hydrocephalus is reversible, these are reversible causes, and even vitamin B12 deficiency is a reversible cause. Lewy body dementia, it's a neurodegenerative disorder, it is usually progressive. So here the answer is A, B and D. Now one of the question could be this only. And another type of question, new question if they want to ask, such clinical question can be asked that they would give you a clinical picture in which the patient is having cognitive impairment. So you have made a diagnosis of dementia. Now they may ask you, which of the following investigation would you like to do? So would you like to do any brain scan in the patient? Would you like to check the vitamin B12 levels? Would you like to check the thyroid function test? Or one option may be all. So such question may also be asked. So please be very careful. Nowadays you will see two layered questions being asked. One would be that you have to first make the diagnosis and then they would ask you the second point. They would ask you the management or they may ask you some other things. So please be very careful when such questions are asked. So always see in the question what they are trying to give you. So if cognitive impairment is given, then you are thinking of dementia. Let's discuss this very important topic and a very important question. Let me see if we can answer this question. Very good. A 70-year-old female brought by the family members as she is having difficulty in doing activities of daily routine. So patient is not able to do the activities of daily routine, and usually when the patient develops cognitive impairment and he is not able to do the activities of daily routine, then we say that patient is having dementia. So patient is having cognitive impairment, can't remember events, so she's not able to remember things. Also she is having visual hallucinations in the last 2.5 years. For the last 1 year, the symptoms of rigidity, bradykinesia also have developed. The image also has been shown and this finding is seen in the brain. You have to tell me the diagnosis. Now very interestingly, there are two important diagnoses which you may be thinking of. One is Parkinson disease dementia and another is Lewy body dementia or Lewy body disease. Now these are close differential diagnoses of each other, and see in this question we have given both. Now you have to tell me what is the right answer. Is it Parkinson disease dementia or is it Lewy body disease? So let's first try to discuss this Lewy body dementia. It's a very important topic. Remember that Lewy body dementia now is the second most common cause of dementia. And what is the first most common cause? Remember, first cause is Alzheimer's disease and now Lewy body disease is the second most common cause. Vascular dementia now is the third most common cause. So remember, Lewy body disease, many questions have been asked on this topic. Now Lewy body dementia or disease, is it cortical or is it subcortical? Remember, it is mixed dementia. So you will see mixed features, both features of the cortex and the subcortex. See, if the cortex is involved, we are seeing a lot of cognitive impairment, and if the subcortex is involved, areas like basal ganglia get involved, you will see a lot of motor abnormality. So in mixed dementia, you will see both symptoms may be seen. So let's discuss the core features of Lewy body dementia. So what is the mnemonic? So we discuss the core features of Lewy body dementia with this mnemonic. Suppose there is a person, Mr. Lewy, who goes for an interview and the interviewer asks Mr. Lewy, show your CV, Mr. Show your CV MR. So this is the mnemonic to remember. C for C. If the cortex is involved, you will see there is cognitive impairment. So there is fluctuating cognition. There may be variation in attention, alertness. Which hallucination is more common in organic disorder? Visual hallucination. See, visual hallucination here is given in the core feature. And since it is mixed dementia, even the subcortex get involved. So you will also see here motor features of Parkinsonism. For example, tremors, rigidity, bradykinesia. And now remember this fourth point, this may come as a potential new question. So FQIC are the future question. This may come as a new question, which is now another core feature added in the core feature list. Remember, REM sleep behavior disorder. So there are NREM disorders, there are REM disorder. So one of the REM disorder, that is REM sleep behavior disorder, that is included in the core features. Also, patient may have some supportive features. Supportive feature means that if these features are present, they are supporting the diagnosis. Sometimes you will see that patient may have severe neuroleptic sensitivity. Neuroleptic means antipsychotic. Now, would you like to start antipsychotic in this patient? You may, because patient is having psychotic symptom like visual hallucination. But patient is sensitive to these neuroleptic induced extrapyramidal symptoms. So one has to be very careful. Patient may actually develop EPS. Then patient may also have, I am highlighting some important points, may have repeated falls, syncope may be there. So they may give you a history of syncopal attacks and they may ask you which dementia you are thinking. Also, patient may have transient loss of consciousness. There may be severe autonomic dysfunction. Patient may even have systematized delusions. For example, there is delusion of persecution. Patient comes to us and says that my wife has been replaced by a stranger. So which delusion we are thinking of? Remember we discussed in the beginning. So can you remember Capgras syndrome? Sometimes you will see patient may even present with Capgras syndrome. So these are some important supportive features of Lewy body disease. In the brain, what finding you will see in pathology, beta, as the name suggests, na, Lewy body, you will see Lewy body. So can you appreciate there is a central pinkish core surrounded by a halo. So these are Lewy bodies, these are alpha synuclein. Also in the FDG PET scan, you will see there is the posterior cingulate island sign. So there is hypometabolism in the occipital area and there is sparing of the cingulate, posterior cingulate cortex in the initial part of the illness. So you will see this posterior cingulate island sign in the patient in the initial stages. So these are some important points about Lewy body disease. Also remember, these Lewy bodies can also be seen, they can also be seen in Parkinson disease dementia. Now can you appreciate, so here we will again discuss this point that Lewy body disease and Parkinson disease, they are important differential diagnoses of each other. How to differentiate? See, Parkinson disease, we know it is a subcortical cause of dementia. Since the subcortex is getting involved first, you will see here it is the motor features symptoms which will develop first, followed by cognitive symptoms. So in fact, in the research criteria, we take 1 year duration, that after starting of motor symptoms, after 1 year, the cognitive impairment would start. While in Lewy body disease, since it is a mixed dementia, you will see cognitive symptoms are present in the beginning plus minus the motor symptoms. Motor symptoms may occur in the beginning, they may occur later on. So now if I ask you the diagnosis bit of this question, now can you answer this question? So you will see here the cognitive impairment have started first, later on the motor symptoms have started. So here the answer would be Lewy body disease. Now what is dementia pugilistica? Because of repeated head trauma, like in boxers, the person may eventually develop dementia. So this is dementia pugilistica, also known as punch drunk syndrome. Also known as punch drunk syndrome. In fact, in one of the exams, this question was asked, which of the following is an acquired cause of dementia? So can I say punch drunk syndrome or dementia pugilistica is an acquired cause? And one more point, remember, in vascular dementia, we discussed vascular dementia now is the third most common cause of dementia overall. Usually we see that dementia have a slow onset, insidious onset, but one of the dementia, which is vascular disease dementia, it has a acute onset, sudden onset. So patient may be a male, more common in males. There may be some vascular risk factor like hypertension, diabetes, there is smoking history is given. Suddenly patient develops cognitive impairment, then you're thinking of vascular dementia. Also, can you tell me one pattern of dementia which you can see here in the vascular disease? Remember? Remember PrepLadder, step ladder. Remember this, very good. Step ladder pattern is seen, very good, in vascular disease. So here the answer is option C. Let's discuss the next question. A 30-year-old woman presents with symptoms indicating that her thoughts are not under her control. She states that she cannot think without external influence and frequently feels that someone is interfering with her thinking. Which of the following Schneider's first rank symptoms does she display? Now let's also discuss one more point in the history of schizophrenia, that is SFRS. Again, you will see a lot of questions are being asked in a clinical sense from the history of schizophrenia. So let me see if you can answer this question. Very good. So tell me, it is representing what? So patient feel that somebody from outside are interfering with their thinking. So let us in fact discuss the SFRS. So Schneider gave first rank symptoms. There are 11 symptoms. Let's try to break them down. The first 3, can you appreciate? Patient says that there are audible thoughts. He can hear his own thoughts or thought echo. We discussed first person auditory hallucination. Or he can hear voices discussing about the patient or voices commenting on one's action or running commentary. So we can say that the first 3 are auditory hallucination. Now please remember, not all auditory hallucinations are SFRS. Only these 3 particular auditory hallucinations are SFRS. One more clinical question can be asked. Now we know that in schizophrenia any hallucination can occur. But suppose if they want to ask question from the history, they may give you 4 examples of hallucination and they may ask you Which of the following hallucination is indicative of schizophrenia? Of course, now we know that any hallucination can occur, but this question might be from the history. So just see if any of the hallucination described in the options, it is matching with the SFRS. So then you can pick that option. Let's discuss the next three: thought insertion, thought withdrawal, thought broadcast. So under the domain of thought, one more domain which we know is the possession of thought. So we've talked about flow, form, content. One is possession. Possession means patient thinks that his thoughts are not under his control or they're not under his possession. Normally you would say, sir, I possess my thought. But here patient says, no sir, these thoughts are not my thoughts. Somebody is interfering with my thinking. So one important abnormality under the possession of thought is thought alienation. So as the name suggests, alien. Somebody is interfering with my thinking, also known as passivity of thought. Now in psychiatry, remember, whenever this term passivity is given, now passivity means it is under someone else's control. It is under someone else's control. So passivity of thought means my thoughts are under someone else's control. So what is thought insertion? Patient says that somebody is inserting thoughts in my mind. Withdrawal means patient says somebody is taking out my thoughts. And broadcast means patient thinks that my thoughts are getting broadcasted outside. Everybody is able to know my thoughts through television, radio, newspaper. My thoughts are getting broadcasted. So remember, these are thought alienation phenomena which are also included in thought in the SFRS. So they may just ask you such clinical question like here in this question, the answer would be it is thought insertion. But let's complete this list. So I hope the first 6 are clear to everyone, right? Now let's also discuss. So we have talked about abnormality of possession. Mein one is thought alienation. One more abnormality, please remember, which we will discuss, that is obsession. Now please remember, this has been asked again and again. Obsession is also rhyming with possession. So obsession is, if they ask you, is a abnormality of. So possession would be a better answer than control, than content. So please remember, obsession is a problem of possession. Better answer would be possession of thought. Now let's discuss the next 3 which you can remember with the mnemonic IFA. So in Bollywood there are IFA words, so remember IFA. So these are made phenomena, made impulses. What are impulses? Impulses means urges. So made impulses, feelings or acts, or you can say made acts or volition. So here what is happening, patient says that there are some urges coming in my mind, like there are some urges to get up, but sir, these are not mine. Somebody is putting these urges in me. Or let us say there is a patient who is crying, but patient says, sir, this feeling of crying, ye meri nahi hai. Somebody is inserting these feeling in me. Or let us say one patient has slapped another patient. You go and ask what happened, why have you slapped him? The patient says, sir, this act of slapping is not done by me. Somebody has made me do this. So this is made act or volition. So patient says that his feelings, impulses or acts, they are not his, but somebody is making him experience it. So this is the meaning of made phenomena. He's being made to experience them. So next time you may be asked question like this. Let's discuss the last 2 phenomena. Again, just see the name. One is somatic passivity. Beta, what is somatic? Somatic means patient is experiencing some bodily sensation. Like let us say there is a patient, Mr. Bholu. He says, I am having pain in my abdomen. It's a bodily sensation. Somatic we just discussed, but somatic means it is because of some external agency. So patient says, I am having this bodily sensation because of aliens. They are sending some waves. So patient is experiencing some bodily sensation because of an external agency, he says, then you are thinking of somatic passivity. And the last is delusional perception. Again, just see the name. But a delusional means in the mind of the patient, a delusion has developed. So patient has given a delusional meaning to a normal perception. So patient experienced a normal perception and after that, a delusion developed. For example, let us say there is a person who goes in a party and he sees a spoon with a crown over it. But you can also see the spoon with a crown. Na? It's a normal perception. He sees the spoon with a crown and after some time he starts saying that I am the king of the world. He stands on the table and says to everyone, kneel in front of me, your king has arrived. Everybody is laughing and giggling, but he is convinced he is the king of the world. So can I say delusion of grandiosity has developed? So after a normal perception, he saw a spoon with a crown and started believing that he is the king of the world. So this is what, this is delusional perception. This question was asked recently in one of the exams, that a patient sees that the bird are flapping their wing or they're flying and he thinks that it is God's message to him that he should run away. So he sees a normal perception and he thinks that God is sending him some signal to run away. So delusion has developed. So the phenomena was delusional perception. So please be very careful. Next time you may be asked questions like this. Okay. Now let's discuss the symptoms of schizophrenia. So we have learned the symptoms of schizophrenia with the name of this movie Dhadkan. Doesn't matter if you have not watched the movie. In the movie nobody had schizophrenia, but from the name of the movie we can remember the symptoms. So remember D for delusion. Again, any delusion can occur in schizophrenia, but most common is delusion of persecution. HA is hallucination. Any hallucination can occur. Most common is auditory. Then remember D for disorganized speech. So all those abnormalities of disorganized thinking which we discussed in the formal thought disorders. So all the formal thought disorders like loosening of association, derailment, tangentiality, neologism, they can be seen. Then remember K, C, you can remember catatonic symptoms, and then we have N for negative symptoms. Let's discuss the last two. So negative symptoms include symptoms like anhedonia. What is anhedonia? Patient says, sir, mera interest kam ho gaya. Things which I used to enjoy before, that interest has decreased. What is avolition? There is decrease in will to do things. What is alogia? See, neologism, logia means word, alogia means less word. Patient is speaking very less. Then affective flattening, we have already discussed that there is decrease in the expression. So as if the emotions are dead. And asociality, see, it is not antisocial. Asocial means less social. So these are the negative symptoms of schizophrenia. So can you appreciate why we are calling them as negative symptom? Because everything is getting reduced. We will end this session. Thank you so much and may God bless you all.